Okay, great. Well, happy Wednesday, everyone. Hope everybody had a great Memorial Day long weekend. For folks who don't know me, I'm Matt Martin. I use he, they pronouns, and I serve as the Associate Director with the North Carolina AIDS Action Network. We're really appreciative for folks joining us today for this quick policy conversation. Over the past couple months, we've been working with our friends at Molecular Testing Labs and Ascendant uh, Strategic, I forget your last
Partners.
partners. I knew it started with a P. Ascendant Strategic Partners to look into some policy around self-collect testing for folks here in North Carolina, especially when we think about folks in rural North Carolina who may not have access to traditional testing and brick and mortar sites. We think that self-collect could be a really great option for those folks, but there are some barriers when it comes to access to those tests and resources for folks in rural North Carolina. So we've been working with these folks to look in some policy innovation that we can do here in North Carolina to make it easier for folks. So with that, I'm going to pass it over to Amanda, who is going to kind of jump right on in. We will let them present, kind of talk through what this policy track is looking like. And then once they finish, we're going to give some time for Q&A. So make sure you jot down any questions. And once they've finished their presentation, we'll be sure to run through any questions that folks have. So Amanda, the floor is yours.
Awesome. Thank you so much, Matt. And thank you to everyone for being here today and being a part of this conversation. We're excited to have the opportunity to talk to you a little bit more about self-collect testing and answer any questions that you have. I do have a number of colleagues on the phone, or on this call with us today, so I want to give them a chance to quickly introduce themselves before we jump into the slides. But my name is Amanda Campbell, and I spent the better part of a decade working in federal policy, budget policy, all related to healthcare, and ended my federal career at the Centers for Disease Control and Prevention, where I was the Deputy Chief of Staff and helped to launch a number of initiatives, but one that's really near and dear to my heart was the Ending the HIV Epidemic Initiative, and is really one of the reasons why I have become interested in self-collect testing since my time in government ended. And we started Ascendant Strategic Partners to continue some of the great work that we got started at the CDC. But with that, let me just quickly let Kyle McGowan and Andy Vogt introduce themselves. Kyle?
Hey, everybody. My name is Kyle McGowan. I was most recently the Chief of Staff at the CDC, working alongside Amanda when we helped launch the Ending HIV Epidemic Initiative. Prior to that, I spent some time in Washington, D.C., at HHS as the Director of External Affairs in the Secretary's office, and then spent about 10 years working for a couple different members of Congress. My background's always been kind of health policy and campaigns. And so we're excited to be here with you all today. And with that, I'll turn it over to Andy.
Thanks, Kyle. I also spent time in DC. I was in the Senate for 7 years, mostly with the Senate Health, Education, Labor, and Pensions Committee, where I handled public health issues. I left Congress about 3.5 years ago, and I've been working with Kyle and Amanda since then.
Great, thank you so much. I'm going to go ahead and share my screen, but Kyle and Andy, please jump in if I miss anything as we go along. And we really want this to be conversational, so if you have any questions that arise as we're going through the slides, please don't hesitate to jump in and ask those, but we will have time for discussion at the end. So let me get the slides up real quick. All right, and then I'm going to go into presentation mode real quick. There we go. Great. Awesome. Okay, so first things first, what we wanted to do is talk a little bit about what a collection kit is. So one of the reasons why we think, as Matt alluded to, this is such an important topic is because self-collected testing really can be and should be a tool for patients to and individuals to be empowered to take control of their own healthcare and make informed healthcare decisions. But self-collected testing is an innovative way that allows individuals to collect samples at home or just in a non-clinical setting, anywhere they may be, just at their convenience, to take samples, send them back to a lab, and get a result with linkage to care through a healthcare provider. And studies have shown that this is a method that many patients prefer due to the ease and convenience of their ability to take the test. It's particularly beneficial for patients in rural or underserved areas that have less access to in-person testing or screening services. So it's not meant to take away from those other services that you may be able to access at a clinic or at the doctor's office, but really more to supplement care where it might not otherwise be able to be received. So I actually have a collection kit with me today, and I'm going to show you some of the components. So the picture on the screen is demonstrating the blood collection kit, but you can do all types of collection as it mentions on the screen. So cup for urine sample. And then there are swabs, and they're labeled for both oral and anal. And then the collection tubes are very simple. They're labeled as well. And then we'll watch a little quick video about how to do the blood sample, but basically what it will go through is that you just take a lancet, which is really simple, do a quick little finger prick, and then there are 5 circles, excuse me, on the dry blood spot card that you fill in. And then all of that gets put into a specimen bag. And then all of that gets put into your envelope and shipped back to the lab. And then you get test results back within a few days, as I mentioned with the linkage to care with a healthcare provider. So for the dried blood spot, since there might be some questions about that, I have a little video here that we'll jump into quickly and watch for just a couple minutes.
Begin by placing each item in the kit on the surface in front of you. Consult the instructions to verify that everything is present. Write your name, date of birth, and the date of collection in the designated fields in month, day, year format. Open the blood card flap to expose the circles on the blood collection paper. Do not touch the blood collection paper. Wash your hands with warm water for at least 30 seconds. Then shake your hands vigorously for 15 seconds to encourage blood flow to your fingers. Clean your fingertips with the alcohol pad. It is best to use the middle or ring finger of your non-dominant hand. Take the lancet and twist off the cap. Press the lancet firmly into the side of your finger until the needle ejects with a click. Keeping your hand below your heart during collection, massage your finger from base to tip to encourage blood flow. Starting at the center, apply multiple blood drops to fill the circle and soak through the collection paper. Do not touch the paper with your finger, as this will restrict blood flow. Once each circle is full, move on to the next circle. If the circle is not full, it will be rejected at the lab. It is okay for blood to extend beyond the lines. Do not add additional blood to a circle once completed or dry. The layering of blood will invalidate the collection. To avoid the collection being rejected, ensure that all circles are completely filled in. If the circles are not completely filled in, or if you go back over a dry spot with more blood, the collection will be rejected at the lab. Check the backside of the blood collection paper. Blood should saturate all the way through and fill each circle of the collection paper. Without closing the blood collection card, lay it on a flat surface and allow the blood collection paper to air dry at room temperature for a minimum of 30 minutes. Do not heat, blow dry, or expose the blood collection paper to direct sunlight. Heat will damage the specimen. When the blood collection card is completely dry, close the card by tucking the flap. Place the blood card into the biohazard bag with a desiccant pack. After sealing the biohazard bag, place the bag in the box, then mail the box inside of the pre-labeled envelope.
Okay. So relatively simple, easy to use, and very convenient as far as the ability to just do it in the comfort of whatever space you have available to you versus having to, in my case, it required childcare, going to a brick and mortar location, getting the sample, and then still having to wait for the results of that sample.
Hey, Amanda, this is Kyle. I just want to jump in real quick while this is kind of, the video is fresh in everybody's mind. You know, has been and will continue to be conversations around the safety of these types of at-home self-collected testing avenues. And we really wanted to make sure that we showed this video and then talk through the safety avenue or the safety aspect of this, in that, this is a small finger prick on your ring finger, and then putting it on 5 little spots on a blood card. This is super safe. Anyone can do this in their home. The directions are very simple. And so I just wanted to make sure that everyone understood, and if there are any questions around the safety aspect of this, that when we're talking about the kit itself and the individual components of the kit, we're talking about a tiny little lancet for a finger prick, and in this specific case, just a dried blood spot card. Sorry, Amanda, keep going.
No, that's great. Thank you so much for jumping in, Kyle. And Andy, if there's anything that we missed, feel free to jump in too. Great. So, here we go. So how does the self-collection process work? So first you'll go and obtain a kit, and that can be done in a multiple different ways. And we'll talk a little bit more about that on the next slide. But in most cases, a provider, whether that's a telehealth provider or a physician, will actually order the collection kit for you. And then the kit arrives. You'll do the samples just as you saw on the video, then ship that sample to the lab, which will analyze it, provide the provider with the results, and then the provider will share those results with the patient. So there is a provider that is, our healthcare provider, that is involved every step of the way. There are lots of different places that you can get a kit. These are just some examples of where a kit might be obtained, but local pharmacies do carry, or some pharmacies do carry collection kits now for a variety of different health issues. You can get them through a digital or telehealth provider. You can get them through public health departments in some cases, as well as community-based organizations, and even from universities in some cases that might be doing studies or a program for a particular condition. So one of the reasons that self-collection is so important is, as we mentioned before, those who are in rural or underserved areas. And this is just a map of all of the STI testing locations within the state of North Carolina. And you can see that in some of these counties, there's only 1 or maybe 2 dots that are representative of a testing location. And yes, there are other locations that folks could get tested, but these are those that are going to be funded with federal public health dollars. And the choices here are limited. And so if there are challenges either from a transportation perspective or a time off work, those types of things, or even stigma related, self-collection does open up and provide another way for folks to be able to access testing and to get the results that they need for a variety of different health conditions. And one of the things that's so powerful is that, I think, unfortunately, COVID kind of did change, I think, the adoption of self-collection and comfort with testing in the home. But a study of over 5,000 patients back in 2021 showed that a large majority, in this case, nearly 85% of folks actually preferred to have the flexibility of being able to use a collection kit versus having to go to a brick and mortar facility. And we saw that from these results, it was agnostic of the individual's geographic location, whether they were in an urban or a rural location. So even those who may have greater access to some of these testing facilities may actually prefer to collect using a self-collection kit. And then we mentioned that a variety of different conditions can be tested for using a collection kit. There are a number of chronic diseases that can be tested for, including diabetes through HbA1c, a variety of STIs as well as HIV that can be tested for using self-collection, as well as cancer screenings, vitamin deficiencies, Lyme disease, testing for substance use, fertility issues, and genetic conditions. So it really is dependent on the person, the individual, and what their healthcare provider recommends. The challenge, though, that we are seeing is that Many of the laboratories that process self-collect kits, or the self-collection kits, struggle to get onto a health plan. And I think, most of us at this point have experienced seeing an out-of-network provider and what can happen when you get hit with that bill, comparing an in-network versus an out-of-network provider. And so a lot of these insurance providers, because of the fact that there's no requirement for network adequacy when it comes to access to laboratory services, they will typically just rely on the brick and mortar services that are available through a physician's office or through other means, rather than also including these alternative options for self-collection kits, and working with these laboratories as well to give patients greater access. And so as a result of that, a lot of patients do end up receiving a bill for the full cost of the services for the labs that they receive. And one of the issues with that is that for many health services, the U.S. Preventive Services Task Force will actually grade services as an A, B, C, or D here. But those that are A or B are intended to be covered at no cost to the patient, no out-of-pocket expense. And so that really will, I think, take many patients by surprise when they get that bill for a service that was expected to be fully covered. And so, for example, for an HIV PrEP test, and as you all know that if you're on PrEP, you have to do the quarterly testing. Some patients we've seen are experiencing an average of nearly $100 per test or $400 per year in order to meet that PrEP medication testing requirement. And so just to kind of put a finer point on this challenge, so one example of a lab in 2022, out of over 15,000 claims for HIV PrEP-related testing, nearly 11,000 of those, or over 11,000 of those, excuse me, were denied by commercial insurance. And so this is really the heart of the issue that we're trying to solve and make sure that patients do not run into in the future. And really the way to solve for that is through a legislative solution. We've seen this be adopted in California, for example, but other states are now realizing that this fix is needed in order to ensure that patients do not get hit with those out-of-pocket costs. And so legislative solution, in our mind, is one that provides reasonable reimbursement for the test kits and the shipping costs, et cetera, but also that requires insurance plans to cover the tests that do have that USPSTF grade A or B, and to ensure that there are no out-of-pocket costs for the individuals. And we can just do that simply by, simple legislation that addresses those issues and makes it clear through defining what a self-collected test is to ensure that those services are covered. So that is the conclusion of our presentation here on self-collect testing. Hopefully it was informative, but we look forward to hearing your questions and discussing more with you all today.
Yeah. Hey, Amanda, I want to jump in real quick. I know we've got a question in the chat about reliability. And I just want to say that, again, these are lab tests. They are collected at home, but they are not tests that you are given a result at home. So these are tests that go to a CLIA CAP approved lab. In the work that we've done and with MTL and others in this space, these are 95% reliability. These are good quality tests in a CAP and CLIA approved lab. Typically where there are issues, it tends to be, as in with the video said, if in a dried blood spot, as an example, if the spot isn't fully filled out, or if there's not enough material there because it wasn't fully filled out, but those are in rare cases. And the reliability is in getting the quality and the amount of material that's needed. But again, those are in rare cases. So I did want to address that. If there are any other questions, you want to put them in the chat or just raise your hand. We're happy to kind of take them as they come.
And one thing I'll add too is as Kyle said, we've worked with a couple labs in this space, and the ones that seem to be doing it right have physicians involved so that if there are positive results, they can explain that to the patient and help them understand what next steps should be. Whether it's more testing or if it's, this is, we're pretty confident in this and here's the kind of treatment you should be on, that kind of thing. But I think that's an important component of all of this.
So we will open it up to the floor. If anybody has any questions, you can either drop them in the chat or come off mute. So ask away. Don't be shy. One question that I know that I can raise that we have had asked before is, can y'all briefly talk about FDA approval and kind of the process that goes along with that? I know that a lot of the different laboratory services are currently seeking that for like the kit as a whole, but as far as like the individual components of the kit.
I might jump in and start. You may know that FDA regulations in the LDT space are changing significantly. They have recently published a final rule that will take effect, I think, July 5th. And assuming that it doesn't get derailed by lawsuits, the final rule will start a phase-in process where tests over the next 4 years or so will have to come basically into compliance with a pre-market review scheme that didn't exist before. So basically, depending on whether those tests that are considered by FDA to be low risk, medium risk, or high risk, it depends on how quickly they'll have to come into compliance, but generally it'd be 3.5 or 4 years. And then there are exceptions for some tests that are already on the market. And there are tests that have been reviewed by New York State, for example, that will be exempt from that process as well, because the FDA, I think FDA is more comfortable with the safety and effectiveness profile of those. But all that to say, historically, FDA has not necessarily approved LDTs. They've been offered more, as what Kyle was saying, under CAP, I think it's CAP accreditation and CLIA licensing, something like that. And so, it's a little bit different in terms of that process, but some companies have actually sought out FDA approval and received that, but it hasn't typically been required. So it's a little bit of a different landscape, but it is changing too.
Yeah, the only thing I will add to that is the components of the tests are all approved, FDA approved for what they're doing. So the Lancet is FDA approved to prick your finger. The dry blood spot card is FDA approved to collect blood specimens. So the components are all FDA approved for what they are doing. The process that Andy is talking about is what I would call the soup to nuts. The collection process all the way to the lab is what is currently being discussed as far as what needs to be approved by FDA, and there's a lot of discussion about that. I know that we've got a couple of comments coming in through the questions in the chat, and one thing that I wanted to address was, can you explain how the result process works and what if you don't have a doctor? The good thing about the at-home self-collect testing, where you collect the specimen and it goes to a lab, is that you have that ability to have a linkage to care. Meaning, if you have this test at home, I always give a pregnancy test as an example, and that's probably a horrible test or a horrible example, but you're at home, you do the test by yourself, and you have this potential life-changing diagnosis by yourself. That is not what we're talking about here. We're talking about a specimen going to a lab, and we're able to build in that linkage of care. Using just MTL as an example, because they're here on the call, if they're doing HIV testing or any type of STI testing, it is a physician that is going to call and alert you on hey, we have this, your test results in, here's the results. And you can build in the linkage of care as far as what the next steps would be. One of the things that we did at the CDC was making sure that funding was going out so that linkage of care, testing is great, but if you're not testing and getting individuals into care, you're missing a step. And so doing it this way allows for that linkage of care to occur. Sorry, go ahead, Russell. Is there something I'm leaving out? I don't want to miss.
Only because you mentioned my company.
Okay.
And to address the question very directly, the question was asked whether or not they have a doctor. We have at MTL, we have a physician oversight group, and they have standing orders, and they are always identified or assigned to a patient by their region or state and so forth. So when they activate the code for their self-collect kit, it goes through a physician oversight committee and standing orders are processed through. So even if they don't have their own PCP, they don't have their own physician that they like to go to, we provide that as part of that service. So there is that constant continuum of care of making sure it's appropriately applied.
Great question, though. I'm so glad that somebody did put that in so that we could explain it a little bit further. We have a new question about how does the company link an HIV positive test result to care? Russell, do you want to dive into that just a little bit more?
Yeah, I'm sorry, I'm reading the question, trying to process it real quick. Okay, if there is a positive result, there is two processes that are activated right away. First, well, three. One, we do a confirmatory test. We check it again just to make sure that we are getting this test absolutely accurate, for obvious reasons. Number two, the physician will be reaching out to that patient to explain, that they had a positive result, that here are your options for care, here are your options moving forward, and they will counsel them through that. If the patient needs additional counseling and needs additional guidance, they take care of that as well. That's all part of the physician oversight group. And then the last thing is done that it is reported out to regional and state departments of health and registry as part of the registry for tracking.
And then one of the questions we have in the chat, Russell, is any age limit on who can get a test and any concern about that. And I would assume that the answer is there is no age limit other than the ability to do the test.
I wish I could give you a solid answer on this one, because right when you asked that, I went, I didn't recall it, but I'm not going to throw out a projected thing. I like what you've suggested there, but I can't give an answer right away. I'll check, see if there's an age limit, and hopefully I'll have an answer before we finish.
Let me scroll back up. We had one question earlier about will they be charged for lab services? And yes, that is the entire issue here, is that they will be charged for lab services in the case that the lab is out of network and not in network with their insurance provider. And that is really the challenge here, is that you would anticipate if you have insurance and the service that you are having done, it is one of those USPSTF grade A or B services that's supposed to be able to be completely free of charge with no out-of-pocket expenses for the patient. To then receive a bill is unexpected to the patient, and one of the issues that we're trying to address through legislative change. And then Jacqueline, I see you have your hand up.
I do, and I figured it'd be easier if I just asked rather than keep writing things. So I work at the state. So I'm the HIV director of the state of North Carolina. And so this is interesting to me. Of course, at-home test kits for HIV have been around for a while. A universal one, as I understand it, that does everything is really interesting. So two questions. The first one is about legislation. Amanda, you mentioned the possibility of legislation. Are you planning, or is NCAN planning to propose legislation to the North Carolina legislature sometime soon about this in terms of insurance? Because you're absolutely right. We are running into some colossal problems with people getting bills they didn't expect, sometimes very large bills for out of network lab testing, et cetera, et cetera. So my first question is there proposed legislation that you all are considering? And then I have a second question.
Yes, so we do have proposed legislative language that we've been working with Matt on, and hopefully working with him and the rest of NCAN to introduce either this legislative session or hopefully in the next one. As you know, sometimes these things take some time to get off the ground and to find the right champions in both the House and the Senate. And so that is really what we are working on today, is just to begin that education effort ahead of Advocacy Day, so that you all are able to learn more about it and see if this is something that NCAN is willing to support moving forward.
Okay, that's a big help.
Jacqueline,
Right now, because I keep my back. Am I back?
You're back. You're back.
Okay. So Melvinia has a question about will insurance cover it, and I can tell you from the calls coming into my office, the answer is not necessarily. That's the problem we're having in North Carolina right now. But I did want to go back to the linkage question for just a second. So Mr. Smith said that the physicians in the company will notify local and regional folks or about the positive test. So I'm assuming that means that you do have a list of who to notify in each state, or more specifically in North Carolina, since that's the one I'm required to care about. Do you how are you doing that exactly? How do you know who to reach, given where clients live?
Well, it's again one of those answers of it depends. Every state, every region has a slightly different approach to it, and we have built in that process. It's constantly updated, but we are covered in every state. Did I not answer all of it?
Quick question that I had in regard to, I know that we've you alluded to California being a state that has kind of advanced some of this type of legislation already. Do y'all have any insight of kind of like lessons learned from California, how that process went? If they had any kind of pushback, what their final language kind of looked like, just for advocates to kind of think through what we could potentially be looking at if we were to move this forward in North Carolina?
I'll let Andy and Kyle correct me if I'm wrong, but I think one of the challenges that they have had in California is that they were, one, trying to make sure that their Medicaid population had access to self-collect testing. And so it has been, I think, a little bit onerous in order to just get the regs updated for their Medicaid program in order for it to be fully adopted. And I don't think that they went far enough as far as having insurance coverage insured for the patient to make sure that out-of-pocket cost does not occur. But I believe those are the two issues that with the legislation that we have drafted moving forward, it's meant to basically make both of those non-issues.
So I have a question. My name's Haley Stout. I'm a regional HIV and STD coordinator. I'm based at Wake County in Raleigh. And I have a question specifically, and I don't think this is necessarily as much policy. I think internally our agency would definitely have to have policies, but I'm thinking about the uninsured, underinsured, or the primary populations that I work with. And so what I'm thinking is, let's just say there's an agency in our region who wanted to purchase the kits and give them out at like an event or something like that for the client to take home. Is there a cost for the lab kit and then a cost for the actual processing of the labs? Like, are those two separate fees?
I'll defer to Russell to answer that question.
I was about to do the hand raise thing. Yes, we can definitely put together a package that goes forward, but there are some straightforward components. There is a test for the kitting, or basically the kit itself. There's a cost for shipping out to the patient directly, and we could probably work a bulk shipment to the organization if they prefer, but let's assume it's direct to the patient. Then there's return shipping, and then there's processing of the assay. But If that kit is never returned to us, there's no processing fee for the assay or for the return shipping. So we do it as a dual billing process. Here's the kit and the ship, and then the ship and the process. That's
And so just a general question, because I know that we've spoken, look, I'm also a prep coordinator, so the whole prep, like I work through that constantly across our region with clients who are getting bills for it. So, so let's just say that, let me make sure that I get this question right. So actually, I think that's just it. So what you're saying is, and I'm sure that there's lots of agencies out there who do this, there could be a possibility that an agency could purchase these bulk kits, do the distribution, and then the labs, there could probably be something that could be set up so the labs could be included. The question is how much does it cost? Like for a single person, if you consider it's shipped to the client ships it back. Because a lot of clients who could benefit from this are just simply uninsured and they maybe fall into the Medicaid gap here.
There are a lot of variations on the types of kit.
Okay.
And the very specific type test, and that the cost range varies rather significantly in there. And that's a bit of a moving target. Again, how much is the kit? That changes. Shipping is the same on all of them, and the assay is has a very large variance on it. So,
Okay, so ballpark, like 250 to 750 or,
you're looking at about 100 to 250 tops.
okay.
And I think you've gone all out at 250.
Yeah. And the only thing I would add here is the tests, these types of tests are typically cheaper than going to a brick and mortar because you're not paying for a phlebotomist, right? The issue is the shipping, right? And so if you were running a day where you had kits that you're not shipping to people, but that you're handing out, those individuals will then, take them home and then ship them back to the lab. Those are the types of things that the flexibility that these types of kits provide you to build out an assortment or a different array of avenues to reach people that are most at risk. Because we all know that if you tell people, hey, show up at this brick and mortar location, you're not going to get the number of people that you want to reach for any number of reasons: access to transportation, stigma. So the tests are, I think MTL and others would be able to work with you on whatever the shipping costs and build out something that would be helpful. The biggest thing, though, is getting the state to pay or insurance to pay for folks that are out of network.
Yeah, absolutely. And I mean, I think just in general, I hope that what you're getting from me is definitely support options for clients. Like, when it comes to prep, telemedicine being an option. We know that telemedicine actually helped with young people's viral suppression during COVID, which was something we didn't expect, but it seemed to be, so the more options that are available for folks to receive any type of care, the better. So, and then, so just out of curiosity, so I understand the focus would be to make sure that insurance companies cover these type of kits. And so am I gathering the conversation together in my mind that this conversation is to make sure there's legislation that would support that or require it from insurance companies in North Carolina? Am I following this correctly?
Yes, that's exactly right. So it is expected typically on the patient side that these services would be covered because they have that grade A or B by the U.S. Preventive Services Task Force. And yet when they use a self-collection kit, oftentimes they get hit with a bill because the lab processing the kit is considered to be out of network by the insurance provider. Exactly right. Yes, Russell.
I just speaking from personal experience, the labs that are in our same boat are experiencing the same thing, in that when we're going to those large payers, think of the UHCs, Cignas, Aetnas, and so forth, the big MCOs, they're all operating on the idea of, we've got 2 or 3 big, the LabCorp, the Quest, and maybe one token other provider, but none of them provide self-collect. So, but they come back with, we've got plenty of coverage, we're fine. So it's not that any of these providers that want to do it are out of network by choice. All of us are trying to get a network, we're being rejected because they say, we're good, no thank you.
Well,
So,
I don't think I can do much, but I would certainly advocate for having them available. So I really appreciate the fact that you guys have brought us together to have these conversations. So thank you very much.
Absolutely, it's my pleasure. And I would just say, Haley, like, we appreciate your willingness to advocate on, especially on behalf of your patients, because that's why it matters.
Yeah, thank you.
Absolutely. This has been a great discussion. Are there any other questions from the group?
I have a quick question, which probably isn't a question at all, but I have a syringe service program in rural North Carolina. Okay. And I just yesterday signed the paperwork for your organization for us to do the dried blood spot. Okay. And most all of our folks have no insurance at all. So my question is, do you think in the legislative, so we've worked out how we're going to pay for that. But do you think in the legislative process, somehow the cost to provide that service for self-pay folks could be included in, like maybe the money that they provide for the opioid settlements, or just from a legislative standpoint for self-pay? So that wasn't really a question, but maybe kind of, sort of.
Well, I think that's a great idea and something that should be considered by NCAN and in coordination with the legislature. Because I think, to your point, coupling the syringe service programs with the testing is so critical to make sure that those individuals that are coming to you for services are able to begin to get linked to care should they need it. And I think that would make sense from a public health standpoint. But I'll defer to Matt on that.
Yeah, I think that is definitely a conversation worth having that I have not really thought through. So would love to continue that conversation, Diane. I think that would be, even if it's not this specific legislation, and talking through like opioid settlements, ways that these can kind of overlap to ensure that folks who are on and underinsured also have access to these services, because we know that a lot of folks in rural North Carolina don't have healthcare coverage and will still get left with the bill. So I think definitely worth thinking through. So I would love to continue that conversation with you and pick your brain.
Okay, thanks.
Russell, do you have your hand up?
yeah, I've got an answer on the age limit. The reason why I was confused was because I'd seen numbers before, but nothing solid. We don't have an age limit. The number that was popping in my head was the CDC and the federal government in general are all recommending that people between the ages of 13 and 64 get tested.
Okay.
So I almost said 13 earlier, but that's because it came from that, but there's no age limit.
Thank you.
Yeah, I will note that I think when it comes to PrEP services, so this is outside of the testing issue, it's based on weight. So I think in like seeking it, particularly self-collect for like PrEP services, you do have to meet like a federal like weight limit in order to access PrEP. So I think probably just like looking into what the end goal is of these collection tests is probably where we should look, as far as like if there's an age limit on that or if there's a weight limit.
Okay.
If I could just, and I don't know, I don't want to call Jermaine out, but he's one of our nursing supervisors, but there are some concerns about parents' bill of rights and how they're impacting our ability to provide services to youth under the age of 18. So those kind of things may very well become complicating. I think in North Carolina, if the provider judges ages of consent, the ability to reason, to know whether to provide those services, or if child protective services need to be involved in those kind of conversations. But that could be something that just adds a layer of complication to providing these services to youth, is the changes in parents' bill of rights that are coming. Sorry, that was sad news. I didn't mean to bring a downer to the conversation.
Sad, but it's the reality. And I mean, I will say, luckily, I think as far as minor consent, when it comes to healthcare coverage in North Carolina, ours is a little bit more flexible than I think that people really understand. So definitely that's something that I need to do some additional research on, but
Well, great. Any other questions that we can answer at this time? If not, Matt knows where to find us. We're happy to provide you with any additional information or resources that you may need.
and I will make a final plug. I can drop it into the chat as soon as I find the link, but just for folks who are hoping to join us for HIV Speaks, that is on June 11th, which is Tuesday after next. We are less than 2 weeks away, which makes me want to scream, but also I'm very excited about. So for folks who are in North Carolina who would like to join us for our Advocacy Day, this will be a policy topic where I think we will just kind of start the process of educating legislators on the importance of self-collect, particularly for folks in rural North Carolina, and kind of sow that seed. So that is June 11th, and if I can find the link, I will drop it in the chat. I will also note that we are recording this, so if you have any colleagues or friends who were hoping to make it today that were not able to, it will be uploaded to our YouTube channel for folks to review. And they can always reach out to me at my email, matt@ncaan.org, and I can get the questions over to folks who may have better answers than I do. But with that, we will give folks back, if there are no other questions, 9 minutes of their Wednesday. I want to say a huge thanks to Amanda, Kyle, Andy, and Russell for joining us and answering so many questions, and really appreciate folks for staying on to answer or to ask questions and get additional information on what we think is a really important kind of step forward when it comes to testing access here in North Carolina.
Well, I'll speak for Kyle and Andy and Russell, and just thank you all again for having us, and especially Matt. Thank you for making it happen. We appreciate it.
Thank you all.
Awesome.
Appreciate it. Thank you.
All right, y'all have a good one.
Everyone.
Thank you.
Bye.